Hello, everybody. We're going to start in a few minutes now, so this is your official call to order. Please take your seat, make your way to the main area. Thank you. Awesome. Thank you so much. This is an inherent crowd, so I appreciate that. We are live streaming, and so that's why it's even more important to stay on point, because there are people that are joining us over the interwebs, and we want to make sure that they know that we are here and not running too far behind. So thank you, those of you who are joining us live. We appreciate that you're joining us. Welcome to the Cambia Grove. My name is Nicole Bell. I have the honor of serving and being the steward of this Cascadia Healthcare Innovation Community. What we do at the Cambia Grove is exactly what's happening today. We convene, identify, and catalyze the next generation of healthcare solutions in our backyard. And so we are best when we have that sort of ideal mashup of those who work at healthcare enterprises of today and bring them together with the technologists and the entrepreneurs who are really thinking about novel approaches to solve our most pressing challenges. And so just for context, for all of you who are here in the room, I have a couple of questions. First of which is, who is here today from out of state? Will you raise your hand? So for those on the interwebs, it's like at least 20 people. Oregon counts. So keep your hand up if you're out of state and not here from Oregon. Okay, so you all know Lily Brillstein is here from New Jersey. And so is anyone from farther than New Jersey? So shout out where you're from. I know we've got Oklahoma City. That's pretty far. Chicago. Oakland, California. Salt Lake City. I think there's a lot of San Francisco Bay Area. You're just not talking. I know it for a fact. Okay, thanks for being here today. Next round of questions. Raise your hand, please, if you're from a health plan. Let's start with health plans. Okay. Next up, raise your hand if you're from a provider system, provider of care. Awesome. Next up, investor. They're all together. Wow, you all found each other. All right. What does that mean? Okay, next up, technologist. Awesome. And entrepreneur. And yes, technologist entrepreneurs count. So wonderful. So thank you. This is exactly what I mean. We've got the ideal, diverse mix of folks here today. Before we get started, I'm going to go through the operational things really quickly. First and foremost, maybe most important, is the restroom at the Cambia Grove. For those of you who haven't been here before, it is out the front door, down the hallway to your left under the exit sign. Water, food, and drink is going to be right here for today. Those are important things. The Wi-Fi is listed up there and in other places around the Cambia Grove. A hint, you will be needing to use your phones later today at the end of the session, and so please get them ready toward the end of the session and have your Wi-Fi loaded if you need it. Okay, also, I mentioned we're live streaming. We're capturing 8:30 to 10 a.m., that part of today's agenda, for future use. So you'll be able to not just read an event recap, but you'll be able to catch these words again at a later time. David does an awesome job synthesizing information and providing the video readouts later. So just in case you don't get it in the moment, you'll be able to refer back to our content later. We encourage the use of Twitter. I have a slide in a moment here that's got everyone's tweet handles that are presenting today, but we have Cambia Grove tweeting, and we have Tiny, who is our Sasquatch in resident, tweeting. You may have walked by Tiny at the front. He's pretty large, and he is the voice of the consumer at the Cambia Grove. So be careful today because our customers are watching, and they will tweet. Finally, we really support people taking selfies with Tiny as commemorating their day at the Cambia Grove. So we highly encourage that as well. You can read the agenda. I mean, the main thing to convey is that we have a series of presentations this morning. We will have a very short visioning session that will set the tone for the late morning. Then we go to a break, and then we have 3 breakout sessions. We will describe and illuminate those breakout sessions for you right before the break as to what those are, so you can choose your own adventure and support the thing that most moves you this morning. And then finally, there'll be a report out, and that's where we're going to have some live polling. So I'm going to introduce our panelists to the stage. So from the Dr. Robert Bree Collaborative, working to improve healthcare quality, outcomes, and affordability in Washington State, we have Dr. Hugh Straley. Please join us on stage. He'll be presenting first. So from Horizon Blue Cross Blue Shield of New Jersey, we have Lily Brillstein. She is, get this title, folks, she's the Director of Episodes of Care in their Marketplace Innovations Group. Her entire job and title is around episodes of care, and we're so thrilled that she's joining us today because she's a national and renowned expert in the field, and we're going to have a lot of robust dialogue because she's joined us. And finally, from MD Save, we have Chris Larson. He's the EVP of Business Development for that company. He is out of the San Francisco Bay Area. They also have offices in Nashville, Tennessee. So each of these 3 are going to have a presentation. It'll be followed by a moderated Q&A and audience questions. So hold your questions till that moment for our panelists. And then, of course, during the breakout sessions, you'll have more opportunities to interact and engage one-on-one with these folks. Our moderated Q&A session is going to be by Tamara Khan. I'm just going to introduce her and have her wave right now. Maybe she's in the front row there, so that we can be efficient and we don't have to do transitions later. So Tamara is joining us from the Silicon Valley. She's a friend of Cambia and the CEO of a new company called Cure Health. They play in the bundle space, of course. And being from Silicon Valley, Cure is spelled with an umlaut and a K. So I'll let you figure that out, but it's apropos, I think, being from the Bay Area. So thanks so much to all of you, and let's get started. I'm going to hand this mic to you, Lily, for when it's your turn. But
okay.
Hugh, you're first.
Okay.
I'll get your slides ready.
My job is easy, but first of all, I wanted to say thank you for having me to really describe what's happening in Washington, to sort of set the stage for episodes. And your presence here really reflects the huge interest in what is being called episodes of care and what in Washington we're calling value-based payment and the move towards value-based payment. But my job is to tell you a little bit about the Bree and what's happening in Washington State right now. And then Lily will tell us what you've been able to accomplish in New Jersey, which is a really extraordinary effort. And Chris will then talk very specifically about some programming and software that is available to enhance episodes. But the Dr. Robert, how many of you know about the Dr. Robert Bree Collaborative? So most of you. So this is going to be old news. But it was formed by the state legislature in 2011, prior to Healthier Washington, prior to the demonstration project, to really address the issues that existed in the healthcare market. We weren't getting what we were paying for, poor quality, high costs, marginal outcomes. And the effort was then to gather stakeholders together to improve and transform care in Washington. Our humble ambition is to transform healthcare. And this is the usual group of stakeholders that are at the table. We meet quarterly with members from quality improvement organizations, employers, purchasers, hospitals, and physician groups that then identify areas of high variation. There we go. Areas of high variation and or poor quality, and develop work groups from experts across the state that then make recommendations that then are taken up by the healthcare authority, who is our sponsor, and are written into the healthcare authority contracts. And this is the past work that each one of these areas could be developed into an episode of care. Very specifically, we have developed bundles for surgical procedures. So total joints, spinal fusion, coronary bypass, and bariatric surgery. But also the most common medical conditions: low back pain, cardiology, obstetrics, and elective inductions, C-sections, all with evidence-based recommendations on improving outcomes and decreasing costs. So you can see end-of-life care with really the focus on advanced directives and promoting advanced directives. And this is an example where end-of-life has been taken up as a project by the Washington State Medical Association and the Washington State Hospital Association, and doing this in a program now that is a national program of honoring choices. So each one of these we hope can become a standard because it was based on the best evidence and the best work that has been done in the state. Our current work is really addressing the opioid epidemic, and there are guidelines for use of opioids, and we have a committee and implementation group that continues to oversee how opioids are used and what are the strategies and tactics in the state that can reduce the use of both acute and chronic opioids. Behavioral health integration is a major issue, and we've just finished a work group that has made recommendations of how this is done. And we have at the University of Washington the AIM project, which is a model for behavioral health integration, and which can be disseminated and distributed throughout the state. But again, these are the areas that we're working on currently. Healthier Washington is the project, a massive project sponsored by the Healthcare Authority using innovation grants that were received from CMS, or the Innovation Center, and is a 5-year grant that is organizing the state to promote innovation and reduce costs. And they're doing that through 9 accountable communities of health. And those accountable communities of health then are linking the community resources within those regions in Washington so that they can address what are the distinct needs for that community, and using recommendations from the BRE or using other elements to promote improved health. And as part of this, the Healthcare Authority has committed that 90% of provider payments by 2021 will be linked to quality and value. So that's why episodes are very important. And I think there's no one here who believes that value-based payment is a locomotive that's moving, and we need to get on it in order to understand how to implement these issues. Dan Lessler, and Dan is the director of the medical director for the Healthcare Authority, has just issued a request for information for value-based payment and for bundles. And this process will be that in April, the RFI will go out, and then to provider groups and asking for where they are in terms of understanding and awareness of bundled payments, or even value-based. And then a value-based summit next October to be held to understand where the state is and where providers are, what is the readiness for us to undertake value-based payment. There are already strategies that are in place that the state has, which are integrating physical and behavioral health, which is a requirement that the accountable communities of health, all 9, have to begin a process to integrate primarily primary care with behavioral health care, but also to put primary care inside behavioral health centers. So this bi-directional integration needs to occur. And it really, in my opinion, is one of the first initiatives that can set the ground or prepare the garden for further innovations in provider groups, as well as get the plans to understand how do we reimburse appropriately for behavioral health integration. Also, encounter-based, value-based in the rural areas and the federally qualified health centers is already going on and looking at new payment models, and the state is sponsoring initiatives to look at new innovations in payment in those rural areas. We also have what are called high-value accountable care networks, and the state has contracted with the University of Washington Accountable Care Network, as well as with a high-value network where Virginia Mason Hospital is a major participant. And there, again, taking the BRIE recommendations and building them into those contracts for these 2 entities. And then there is a Greater Washington multi-payer pilot through Northwest Physicians Network to look at innovations in payment, as well as with the Summit Medical Center. And then the state healthcare authority has contracted with Virginia Mason on a bundled payment for total joints. And that is going on now, and patients are being enrolled in that. So that's another laboratory where we can learn from this. So these are, in my opinion, here are some candidates for the state with surgical bundles, which we have, the BRIE has developed, and the ones I showed you. Behavioral health integration, which is a requirement for all of the ACHs and part of Healthier Washington. And then I think appropriate opioid use is an area, because of the epidemic, because of the fact that people are dying of this. This is an area where we need to look at how can we develop an episode or appropriate reimbursement for appropriate opioid use. So that's where we are in the state. Healthier Washington, you'll hear about the Transformation Project, which is the Medicaid waiver project, which is an important element in terms of developing innovations and then earning that money back, which amounts to about $1.2 billion over the next 5 years. And that's why innovations are so important for us to understand and to learn from. And that's why I'm very excited to learn from Lily's presentation about what they were doing in New Jersey. So, thank you. There you go.
Can you hear me? You can't hear me. Now you can hear me. Okay, so I hate when I have 2 things to do. Oh, look, it's at the end of my presentation now. Okay, now we're at the beginning. So I'm so happy to be here. I love this groovy place, and I think the work that's being done here is really exciting. And I'm so happy to share what we're doing in New Jersey. But I always have to say, when Dr. Richard Popiel is in the room, you know, he's really the guy who sort of had the vision at Horizon. He started the program. He birthed the program. I just got lucky enough to come in after he left and continue to grow it. So probably a lot of the questions that you're going to have about the beginning, he will be able to answer better than I, so don't let him out of the room before you get your questions answered. So this isn't the most beautiful graphic in terms of its quality, but I just have to point out, an article was done about our program not that long ago in Health Leaders, and they used this image, and I was so thrilled. It was called Provider-Payer Peacemaking, and I love that it has the patient and the heart in the middle, and the provider's clinical arm and the payer's business arm there. So I use it on some of the covers of my presentations. So this is the state of New Jersey, and just to give you a sense of what's happening today in New Jersey. So again, my role is Director of Episodes of Care for Horizon, which is the Blue Cross Blue Shield plan in New Jersey. Horizon has had a very long-standing commitment to value-based models, and we have a number of models in our state coming from Horizon. We have 4 million members, including our Medicaid line of business. And right now there are about 1.6 million members of the membership attributed to some form of value-based model there, right? That's pretty exciting. So we have the kinds of models that we have. We have network alliance partners, which are system-wide partners who are tied in with us in terms of our goals. We have accountable care organizations. We have PCMHs, which really was the beginning, right? The focus was and resources were really directed towards primary care. And then we had the episodes of care model, which was really kind of the last model, I think, to be introduced. And it was really the model that we adopted for integrating specialists into this whole concept of value-based model. I know you had some pre-reads, but just in case you didn't read it, and just in case there's anybody here who doesn't really understand the difference between fee-for-service and fee-for-value, when I think about it, I think about fee-for-service being all of the care, the focus is all of the care that's rendered by one particular physician. And when we think of fee-for-value, and episodes or bundles is a fee-for-value model, it's about all of the care that's rendered to one particular patient across the full continuum of care. And so that's really the big difference, and that's what the other big difference is in fee-for-service. Payments are made that have no connection to how well a patient does, what their outcomes are, what their experience is, and the fee-for-value model is all about that. Oh wait, I think there might be some animation here. Oh, I kind of blew it. Anyway. And again, just to level set, I think you have this in your packets or your pre-read. When we talk about episodes of care, we're talking about that full spectrum of care. And so, it's not, if it's a hip surgery that we're looking at, it's not just the surgery and the inpatient stay, but we're looking at that prehab period, right, of labs and radiology. We are looking at the surgery and the anesthesia and the acute stay. And we're looking at I love when people take pictures of my slides. That makes me feel really good. Thank you. We're looking at the post-acute care portion of the program too. Where did they go? Did they go to a SNF, rehab? What were the days like, et cetera? And what should have happened in the animation, those hands should have started coming across the page. And the idea is really to foster coordination and collaboration and communication across the continuum. And it's like a spectrum, right? The rainbow, you get that? And the goal, the ultimate goal is really for us to look at apples to apples, if you will, to look at like patients with like outcomes and begin to study the variation in the care and cost of care so that we can optimize both. So when I think about episodes and bundles, one other thing I should say, episodes and bundles are often used interchangeably, and typically I'm pretty strict about calling the program we have at Horizon Episodes of Care program, not bundles. Bundled payments, people are usually talking about a prospective payment, money that's a bundle that's paid up front for a set of services before they're rendered. Our program is retrospective, and so I'll describe that. It's very deliberately started as retrospective. And I think also you don't really get the sense of the quality of care that's inherent in these programs when you just talk about bundles. So anyway, I put this slide up because I think it's really important to understand that this movement from fee-for-service to fee-for-value is evolutionary. It hopefully will not take 10 billion years, but it does take time, and we do have to have patience. And there are a lot of places around the country, and those of you in technology and other roles probably have seen this, that folks have tried to go from fee-for-service directly to risk-based models, and they haven't really done as well, right? Because there hasn't been time for everybody to figure out what the new roles are and how to create success and how to kind of make it work. So our philosophy really has been to meet our providers and our stakeholders and our partners where they are and build the program from there. So one really good, smart question that Nicole asked me to address was, what, and Richard too, is, what was the cadence of episodes that you rolled out and why? And, why does it take so long? And when did they come to be? So I put this slide together, which I hope that you can even see in the back, but I'm sure the slides will be made available if not. The original launch in 2010 under Richard's direction were 5 practices, orthopedic practices, doing hip replacement and knee replacement. It's a very common place to start in episodes because there's a lot of them. There's a lot of variation in the cost of care, in how they're done, and they're easy to define. They're very discrete. You actually have a surgical procedure, and you can build an episode window around it. So we had those up and launched in 2010, and when I arrived in 2013, they said to me, your job is to scale this. We've seen enough success in the improvement in quality and patient experience and reduction in cost of care. We want to grow this program. And so what we wanted to do was sort of build a portfolio that was diverse in terms of everything. So we wanted to add not only procedural episodes, but we wanted to add hospital-based episodes, non-hospital, low-cost episodes with high volume, high-cost episodes with low volume, chronic, messy episodes. So we launched again. You can see the first model, the first new episode we launched in 2013 was knee arthroscopy. Was really low-hanging fruit for us, right? Because these were the orthopedists. They already understood the program. Oh, I should tell you, from 2010 till 2013, the cumulative number of episodes that were done or completed was 1,100. So that meant 1,100 members, patients, went through episodes in that 3-year period. And this year we'll have in excess of 20,000 episodes that will complete. So the first episode that we launched after hips and knees was knee arthroscopy. It made sense. Our docs understood the program. It was just a new, different procedure. We then launched low-risk pregnancy. Pregnancy in New Jersey is an enormous opportunity for us. Those of you who aren't from New Jersey, and I think that I'm probably the only one here who is, or well, maybe not originally, sorry. We have the highest rate of C-section in the country. It's sometimes Louisiana, but most of the time it's us. And so it was a metric that was really important to us, among other things, in pregnancy. So this has been a really important episode for us. We launched it originally with low-risk pregnancy, just to get our feet wet and see if we could build it, how it would work. And I'll describe that in a little more detail, but I know I have 20 minutes to get through all this stuff, so ask me later. We then did colonoscopy, and a lot of people say to me, why on earth would you do colonoscopy? Where's the opportunity there? So that's one of those low-dollar, very high volume episodes that we have, right? We have thousands and thousands of members who go through those episodes every year. There's opportunity around place of service, around anesthesia, and it's also a place, there's so much opportunity in the GI space. It was a place to learn. It was a starting place for our docs to learn. In 2014, so pretty quickly, our docs were saying to us, our OBGYNs were saying, we want all of our patients in these pregnancies, we want low and high risk. We rebuilt the episode to include both low and high risk pregnancies. So probably 80 to 90% of the deliveries that are being, the babies that are being delivered by episode docs are included in the episode now. So in 2015, we launched into sort of the chronic space, right? We had, some people would say pregnancy is chronic, but it ends. And so, and it ends well, usually. In 2015, we launched a breast cancer episode and a heart failure episode. So these episodes are different. They don't have a distinct beginning and a distinct end, although in order to measure, we have to create some proxies that allow us to do that. 2016, we had a whole slew of launches that you can see there. One of the most interesting ones is a very small episode in Crohn's disease. It's really Crohn's and ulcerative colitis that we launched with a fully integrated behavioral health component. And I could not agree, Hugh, with you more that integrating physical and behavioral health medicine is so important, and the episodes model is really a perfect place to begin to do that. We didn't do it perfectly, and we have some work to do on that episode, which I'm also happy to talk about. Very, very quickly, we have a number of oncology episodes that we have launched. I don't think I have this in my slides, but typically for the episodes that we have launched, we do the stratification to get to those like patients and like outcomes, right, the apples to apples. We typically do stratification based on information that lives on a claim. We can get like enough patients having babies, having colonoscopies from information that's on the claim. But when we get to oncology, we really couldn't do that. We had to, you have to look at stage of disease, size of tumor, HER2 receptor status. And so we use a different tool called CODA that allows us to extract information out of the medical record, and we get a very, very clinically precise episode or bundle down to sort of the biomolecular level of disease. Fascinating. So now we begin to look at Macoun to Macoun and I don't know, what are the Washington State apples, Gala to Gala, as opposed to just apples to apples. It's fascinating. And then this year, we launched a low back pain laminectomy without the fusion, and I'll talk about why that is. I don't know when I'll talk about that, but maybe in the breakout session. Diverticulitis, GERD, shoulder replacement episodes. And this year, we're going to have I haven't even talked about the fact that these are retrospective and what that means. So let me stop before I tell you that we're going to launch. No, let me move on and do it. So at the end of this year, we're going to launch our first prospective episodes, sort of true bundled payments. And those are going to be in the space of breast, colon, rectal, and lung cancer. On the next slide, I'll talk you through very quickly how our model works today, retrospectively why it is, and I am probably one of the country's biggest advocates for starting with this model. It's a no-risk model that really has a very collaborative spirit and allows the payer and provider to work together to figure out how to create success. But it also means I know what's not great about it and where it doesn't work so well. And for these long, chronic episodes, it's not the best model, right? Because it takes a long time after you do the work with the patient to actually get the incentive payment. And so a prospective model works better. So the way the model works today, and again, as I said, it's very deliberate. It's a retrospective model. We identify a practice who I think of as a conductor because they're orchestrating care across that entire continuum. And we work typically with physician practices. We have some hospital-based episodes, but our model is different than the CMS model, and it's different than some other models around the country. The philosophy really is that the docs are the ones who are making the decisions about, most of the time, where the care is rendered and what the care is that's rendered. So the way it works is we contract with a conductor, with a practice. They become sort of the accountable party for the episode. And there are metrics that are established between Horizon and our inaugural partners, right, to determine what are the key, most meaningful metrics for this episode. So a key point is it still sort of rides on that fee-for-service chassis. Everybody continues to get paid at the fee-for-service rate in accordance with the contract they have with Horizon. There's no risk there. But if the quality and patient experience metrics and the financial targets are met, they share in savings, and they're savings that are achieved across the full continuum of care. So when people say to me, it has been hard, and I have to talk about barriers, it has been hard to get partners, I usually say, it's like selling Cracker Jacks at the ball game, because who wouldn't want to get into this? It's an upside-only model. If they don't meet metrics, I should say, they don't owe us money back. And we don't have to smack our partners to get them to sort of figure this out. We work with them. And usually the first thing that happens is if we have a partner that hasn't met the metrics is I wake up in the middle of the night and think, oh my God, did we do the budget wrong? Did we calculate something wrong? And we really work together to identify opportunities. And we have a really fun time doing it, I will tell you that. Very, very briefly, am I way over the time? Okay. So when we were in pilot mode, there were more than 200, mostly process measures that were being collected on every episode. So I think every time somebody looked or touched a patient, we had to know about it. And when you're in pilot, you have to do that, right? You have to be at that micro level. Today, when we scaled it, we thought we don't have enough time or energy, and there are process measures being looked at elsewhere in the organization. We really want to be able to look at what's key, what's most meaningful for this particular episode. We identified 4 or 5 standard metrics in conjunction with our quality advisory committee, which I call the QUAC, and with our partners that we measure across every episode and every specialty. Things like rate of readmission. We look at extended use of opioids for the surgical and some other procedures. We look at ER visits. I forget what some of the others are, but I'm happy to share those. And then we work with our inaugural partners, the partners launching with us to begin with, to identify between 2 and 4 episode-specific metrics. So things like C-section for a pregnancy, pre- and post-functional assessment on the joint episodes, adenoma detection rate on colonoscopy, things like that. We also do have, one of the things I should say, this is actually really key in our program. When we were in pilot, we used member-specific risk-adjusted financial targeting. That meant that every patient who went through every episode had a specific financial anticipated cost based on the comorbidities and risk factors of the patient. So they were very precise, but they were very labor intensive, and also, as the payer, we don't always know what they are, what all those comorbidities and risk factors are till the claim comes in. So we were never really going to build great relationships if we said to the doc, you take care of the patient, you do everything, get them better, and then we'll tell you what we think it should have cost. They already hated us enough, so that was not a model that we thought would work. So we actually settled on what I think of as practice level case mix adjusted budgeting, where we essentially simulate 2 years of historical data for a particular practice, meaning we take practice's claims data, we run it through our algorithms, and we look and we see what would it have looked like had they been in this program over the last 2 years. And we will compare it to others within the region, which can be vastly different, right, having maybe nothing to do with quality. But if they do appear to be extremely lean, we'll apply sort of an additional cost factor to give them a higher budget. We don't want to punish the provider partners who have already begun to do transformative work. But we'll take that 2 years of data, we'll look at the average, we'll apply a medical cost trend factor, and we'll establish that as their target. So they're sort of competing against their own history. And we work with them to identify what those opportunities are. What does it look like? Is the opportunity in post-acute care? Is the opportunity somewhere else in the continuum? And because of that, when we moved to this model, we recognized very early on that there could be, if there was one medically catastrophic case in the mix, that could destroy an opportunity for a practice to share in savings. So we built in a sort of outlier protection. And actually, we were so generous about it that we started pay, and we had a cap over which we anyway, without going into all the details, it became so generous that we wound up paying, maybe I shouldn't say this on live streaming, but we wound up paying for things that really weren't savings. They were overspending by the practice, and it was a lesson learned. We had to swing the pendulum back the other way and say, okay, we need to figure out a different way to protect the providers but not pay for stuff that actually hasn't happened. So I think I kind of talked about this a little bit. How do we determine which episodes? What's the cadence? At which we sort of bring them to market. What's the provider inclination and pushback that we've received, and what are the changes? And really quickly, again, we really wanted a broad portfolio. We wanted to test the model across all sorts of episodes, and that's what we've done. And Horizon Blue Cross Blue Shield is this very conservative organization that was lucky enough to have the birth of this Horizon Healthcare Innovations, which is now just a market innovations team, where we get to test a lot of cool stuff. And so we continue to do that. And in terms of the cadence, some of that's determined by our partners. They'll come to me and say, the GI docs, we really want to do more than colonoscopy. We want to do diverticulitis or GERD. We want to do Crohn's and ulcerative colitis. Some of it's determined by what's going on in our own state, like pregnancy. And some of it's just based on what do we actually, what's in our book of business that looks most critical that we really need to be addressing. Where's the most variation? We have had very little pushback. I know that's surprising. We're East Coasters, but we've built a program. We've built a program that, when I first walk into the room, or my team now walks into the room, there is some skepticism because the historical relationships are adversarial between payer and provider. And so their heads are cocked, like my little dogs, thinking, like, what are you talking about, lady? And, then when we describe the program and that there's really not, it's really no risk to them, which they don't really usually believe at the beginning, eventually, I certainly haven't introduced this to anybody who has ultimately not joined the program. So, again, going back to that evolutionary slide, this whole movement to value-based care is, in my view, evolutionary, and we're all at the beginning. We're ahead of the pack in some respects, but we're still at the beginning too. And so we met where they were, and we were sort of patient about it. Surprising, right? And again, so some of the barriers, and there are lots of barriers, I think, at the payer level. The systems aren't set up. The systems are set up for fee-for-service, and payers are afraid, like, how am I going to make this work? How do I pay for this stuff? And there are some easy ways, I think, to do that. There's a huge focus, even when we talk about value-based care, to get people off of the concept of unit cost and more into the concept of the total, how do you articulate the value that you bring to the total episode and not focus on that individual unit cost of care. And I think probably we'll talk about this in our breakout. There's great opportunity, I think, for non-traditional partners in these episodes around that. A lot of suspicion and partner distrust, and the patient has typically been outside of the center in fee-for-service. Our keys to success, without going through that whole slide, is really about partnership and simplicity. We try to keep it as simple as we possibly can. We took 200 metrics, we boil it down to 4 or 5, and 4 or 5 that are meaningful to the provider, to our partner, that don't create additional burden. If I can get the information from claims, we will do that. If we can't, we'll ask them, what are you already reporting? And we'll take it in the format they're reporting it in. So there's really a lot of mutual respect, and it's, I come from a public health background, so it does my public health heart good to see this. And I think this is probably my last slide. The collaboration for me is really about building trust, and I like that Nike tagline of "Just do it." None of us is going to get it just perfectly right at the beginning, and we go in sort of knowing that and accepting that. We go in trying to do something that is going to be better, and we always go in knowing that we and our partners will be open to making changes as changes become clearly evident, that they're needed. So it's really been fun to do that, and a lot of communication. Oh, it wasn't my last one. This is definitely my last one. So the retrospective model has allowed us to really build a lot of trust. It's allowed us to work with our provider partners together, and for us to figure out together how to create success in these models. So, who knows what will happen in Washington? Who knows what will happen over these next several years? But I do really think that the docs in New Jersey and in your state as well, I think will be among the most well-qualified to be successful in the APMs and some of these other models, because they've had an opportunity to kind of do it in this no-risk environment. And for us, there was really no risk, because they weren't going to start suddenly performing more poorly because they had an opportunity for an additional incentive. Okay, that really is my last. Thank you so much.
I'd like to hear everybody keep talking. It's pretty interesting. So I'm Chris Larson. I work for a company called MD Save. I'm the head of business development. Last month we sold about 4,000 prospective bundles, and paid out about something over 10,000 payments. So it's been a pretty complex journey. I'm a student of the healthcare ecosystem is how I like to think of myself. Done minimally invasive cardiac surgery development, helped move sinus surgery in the office. Most recently, I was working with patient remote monitoring. And then I heard about this trend towards the high deductible. And I was like, everybody is going to start shopping for healthcare online. That's actually funny because it's not totally there yet, but consumers are looking around quite actively for information. So I think about this as the Walmart mom. So if you take a look at this woman, she's making $50,000 a year maybe, has a deductible of about $5,000, and basically is not exactly sure what her costs are going to be. And that's the person that we started focusing on when we were building our website. So this person is looking for labor and delivery services, simple things like imaging, laboratory. I had a thing at one point in my life that if we could ever sell colonoscopy online, we could do it with anything. That is actually becoming true. The costs are very expensive. They're looking at all kinds of different things, heart surgery, orthopedic surgeries, the works. It's interesting, they're trying to get their information from their provider, and they're asking increasingly about cost information. I know that there's a lot happening in this category, but there's not a lot of satisfaction. There's tons of different websites out there in the world that are helping people find out, what an estimate is. But in healthcare, it's important to realize that coding is based on degree of difficulty. And if you have that involved in it, it's all going to have to be retrospective, and your bill is not going to be able to be predicted. So what we tried to do is always look at that point of view from the consumer anytime we're dealing with any kind of providers or anyone. They're looking at a lot of Yelp-style reviews. I think we all know what that is. It's kind of like this, everybody's talking about quality ratings and this and that. It seems a lot like most of the quality ratings for things that are very common, like imaging and outpatient surgeries, are simply based off the quality of the person at the front desk and the office experience. The hospital systems, and that's how we look at the ecosystem, as we focus primarily on the hospital. They essentially are just dealing with phone. There's not a whole lot of other touches. Salesforce.com, big company in San Francisco, has this whole health cloud thing that they're trying to do to try to integrate everything. There are some people moving as sort of like some cares coordination centers, those types of relationships, but there isn't a lot of technology involved in the hospital system right now in engaging the consumer. The advisory board wrote an article recently based on this trend that people are looking around and they're leaving their systems. It used to be just a huge loyalty, all-you-can-eat kind of healthcare in your community, but now people are starting to be discerning and they're actually moving themselves to other places to get care. And if they don't like their care, they don't pay their bill. So there's a lot of different components to what's happening in the world right now on the consumer side. And I think that the cool thing about being here is this collaboration and bringing everybody together and focusing on the consumer, because most conversations we have in healthcare don't involve the patient at all. Like, we're not thinking about it. We're more like, how do we handle this bill? How do we code that? What do we do about getting payment here? Those are the conversations that we all talk about most of the time. And those are the conversations that I think we lose sight a little bit of what we're trying to accomplish in healthcare. So if we had this lens of just looking at it from the consumer point of view, we thought it was going to be pretty easy because we're like, well, of course the providers are going to want to get the word out there and market themselves. But in order to execute a marketplace in healthcare, we had to build infrastructure because nobody really had any concept of how to price anything. So essentially, we created this very simple bundle payment platform. And then we began to engage consumers in a self-pay manner only. And now we're expanding into other things. So what I said about those bundles that we sold, that ranged from simple labs to x-rays to colonoscopies to bariatric surgery We had one man in the last over a year and a half bought 2 MRIs from us in Texas, drove to Oklahoma, got his hip surgery done. Had somebody from Colorado buy a balloon sinuplasty procedure in Oklahoma City, fly down there and get it. People are starting to move around, and they're really appreciative of the service because they're worried about their bills, and they're worried about what's going to happen when they get them from multiple parties. We've all read about people being out of network. We've all heard about, various charges being added. We're trying to help that be stopped. So essentially what we've done is we've gone through, made a bundling platform, try to figure out how to bring value to the provider, because our belief has always been that the provider is the center of healthcare, and if we can't benefit the provider, then the whole ecosystem is going to have a problem. We can start in a lot of different places. We have a little bit of a chicken and egg model. We could say, let's create huge consumer demand and then push the provider, but to create that demand is just logistically very challenging, and I don't know if the providers could ever be pushed. We could also say go to the employer, push the provider. Again, there has to be a collaborative relationship. This is a really nice opportunity because I really just don't see payers and providers sitting down in a collaborative manner very often. It's super impressive to listen to Lily talking about what she accomplished in that marketplace. It's almost unbelievable to me, given the conversations that I've had in the healthcare system. So essentially what we did is we created a clearinghouse and used the rules. So we used to have people look at this like it was possibly illegal. I'm totally serious. In fact, a large health system that's possibly based in Seattle actually did declare it as illegal through a bunch of California attorneys, which is really kind of ironic. So what we have been looking at is we have a technology team in San Francisco and a healthcare team in Nashville. And Nashville, as you may know, is very big on the rules and regulations of healthcare. So what we did is we took a specific clause in HIPAA that said essentially a consumer could purchase healthcare in whatever manner that they choose. And that's what the foundation of kind of our software system is. What we also did is a clearinghouse. So for example, there are many of these contracts that say, okay, you have a best negotiated, you can't offer your patients any less price. We're essentially selling excess inventory. So we created a platform that said, okay, you can have your $3,000 MRI from the motorcycle accident, but you can also get the $500 MRI for the kid who got hit in the head with a baseball. And while we're doing that, the real innovation from my point of view came from the payment side. So we raised a bunch of money, we had a platform working, we were getting the marketplace going, but we had a hard time paying. And one thing that you have to realize about bundled payment is it's payment, and people want their money, and there's a lot of parties involved in all these bundles. And we were gonna hire, there's no accounting system out there that we could find that would work, and we were gonna hire 10 new accountants just to write checks. Very healthcare-oriented thing to do. Our technology team came in and said, let's just invent an accounting software, and we'll use that. And that completely made sense. So now all those 10,000 payments that I mentioned that we made all happen within 4 days. So the way we do everything we do kind of lean startup, very agile development. This platform here is based off of Medicare. So what we did is we took the entire CPT database and consumerized it. And what I mean by that is we made it make sense to consumers. So for example, you're not getting a colonoscopy with a palpectomy. You're not getting a colonoscopy with a biopsy. You're just getting a colonoscopy. You're not getting an x-ray of your big toe. You're just getting an x-ray. And what we realized is that the facility fee drives the cost overall. And the physician's fees, surgeons or radiologists, don't range that greatly in most situations. And then with anesthesia, we took an entire database and applied it to all the most common procedures to figure out what the average time was. And through the School of Hard Knocks, we came up with a number that anesthesia would be agreeable to. And we do the same logic with pathology. We sit down in a room with everybody at the same time, and we say, this is what Medicare pays you. How does this sound? And generally, we end up at about 140 to 150% of Medicare for most things that we sell. And what we do sell is mostly imaging and outpatient surgeries. So as we move forward and get increasing, it seems like the percentages are changing on the inpatient side. So let's talk about that provider value. I think this bundle payment thing, to Lily's point, like as far as her incentives and why wouldn't you do this, makes a lot of sense. We have to think about incentives and why people are doing things. We can't just trust the fact that everybody's trying to care for somebody. So this fast payment model has been huge for us. The fact that we guarantee upfront all the money has been a big deal. So consequently, that's why the prospective bundles is taken off. We have a lead gen concept, right? So it's a website. So when we talk to providers, everybody says it's like magic because everybody thinks the internet is magic for that kind of thing. Right now, though, the marketplace isn't necessarily shopping for specific surgeries to buy them online. It's a little early for that still, especially depending on the marketplace and how good the economy is. Like if you look at the economy here, it's exceptional. I would imagine everybody here is very well insured. That's not the case in all the markets in the United States. Definitely not the case in many of the southern states that did not take the Medicaid expansion. What's really happening from us is more like a referral development tool, and most of our patients are provider directed. So they're getting caught in their referral office, or they're getting caught when they go to the imaging center and they're saying, how much does this cost? And they have a choice. It's the charge master or it's go through us, through MD Save, which gives you the comprehensive bundle, one fee, no bills, closes everything out. The other thing that's really been a big deal is our call center. So because we're e-commerce and we have e-commerce technology, we know where everybody's kind of coming from. Like if you look on your phone at our website, you will all have a different phone number on there, for example. That's basically how we start tracking the buying process. And we've realized that people buy healthcare kind of like they buy TVs. They touch different things, they look around, they try to stay close to home. If it doesn't make sense to stay close to home, they'll drive somewhere and get it. This communication pathway is really a big deal. So I don't really feel like you can separate bundles and consumer engagement because at some point when you make a bundle, you have to engage a consumer on it. And all that has to be very smooth and straightforward and go really well because it has lots of opportunities for things to go wrong. So what we do is we have a system in the back called MD Save Direct that essentially drives everything. And that could be like a cash register model where, say, for example, you go to the emergency room and you get a bunch of things done and you want to know what your bill is. We could make a bill right there. We can make a bill in like a care coordinator model where we could say, you got image and labs and sutures, and now you need a lap chole. Why don't you just put all that in one thing? At this point in time, we're only doing that really for self-pay, but we have mapped out that we could take any fee schedule from any payer, but it's really a function of us finding partners. Same thing with the private marketplace. So there's a lot of people who don't really want their pricing out there, but they want to engage specific employers or groups or whatever. There's a private marketplace where it's just purely cash. So we have like a buy side and a sell side. So on the sell side, the providers are trying to sell the procedures, but we can put the cash register anywhere we want. Like we could have a kiosk here for anybody who is, needed a flu shot across the street or something along those lines. We've looked at a lot of different models like that, and we feel like that's beginning to increasingly happen across the United States from a provider point of view. You're seeing a lot more customer service-oriented provider groups starting up. So everybody always asks about cost savings and then execution. So the first most important thing is in this situation, and I believe I read this, I'm not sure exactly, but it's really just to get everybody in the room on the same page with the same goal, and then just figure out what the logistics are. So for us, it's super important for us to have the CEO, CFO as the leader of the conversation and be directing their hospital systems into this endeavor, because it is worthwhile. Like, I'm optimistic that this is going to be extreme quality enhancement tool for people, as well as a financial benefit. And once the leadership gets on board, it's pretty simple to have the surgeons and the radiologists and the pathologists come in the room and kind of figure out how we're going to build these bundles, what everybody needs to get paid, and go forward. And we have this cool software tool, but what I would say is even more unusual is that we have a team of about 15 or so people that go around and they know how to use this software and they know how to speak that language and they know how to answer all the questions of the details, because this business is all about the details. And that has been a really serious strength of ours. And we're not, and basically when I look at like other companies or consultants, they have reams of Excel files, they have lots of legal contracts, there's claims analysis, and we've taken a really lean approach with it and started small, and now we're working our way up. And I believe that as we get into claims analysis, we're going to start knowing what the more quality is like, and we're starting to set market prices in different categories. And that's been an interesting trend that I think it should be noted, I guess, from this group's point of view, because it's for sure, like, the demand's there from the consumer side, and then the providers are willing to do it. I think that I would like to see the bundled program, just like, especially within context of BRIE collaborative or whatever, just expand rapidly, because I think it could help a lot of people. That's it.
I'd love for all the speakers to come back to the stage if they can. Can you guys hear me? Nope. Yeah. Does that work now? There we go. Hey, there we go. Awesome. So lots of information there, and I've been gathering questions from various folks, and we're going to take some more from the audience as well. But to kick it off, I wanted to direct a few questions to the three of you to start some conversations around how we might collaborate on some of these topics. So my first question, Dr. Straley, is I heard from some folks in the audience that you've done some really innovative work in one of the most challenging dimensions of value-based care, appropriateness. And it's a real puzzle that a lot of us struggle with. So I'm wondering if you could speak a little bit to how you define appropriateness, and then I'm going to ask Lily how we might be able to leverage that definition in incentives for providers.
Yeah, thank you. Well, I haven't done the work, but the BRIE, the collaborative, the stakeholders have. And as Chris was speaking, and Lily, I was thinking, as I mentioned, it's almost three different worlds that we've created here. Because for Chris, then I asked the question, what's the appropriateness of these bundles? You know, because that was one of the issues that we asked in these workshops, in the workshops that developed these recommendations, to look at the best evidence for what is the most appropriate way to intervene. And so take total joint replacement. Appropriateness is built into that based on what is the preoperative assessment, what's the disability that exists, what are the tools used to assess that disability before a decision about surgery is made. And so there are recommendations really built to address the appropriateness of that. As well as then there are warranties with each of the bundles, and the warranties are that the bundle will not pay for preventable complications, and the preventable complications are listed as well. So this is a much greater prescriptive process than what you described, Lily, or what you described in your bundles. So for me, the question then is, how can the BRIE or the state of Washington in its value-based journey use sort of your models and your model to enhance value and to drive better care at a lower cost? But ours are really a very evidence-based process using the best practices and the best evidence to then create recommendations for guidelines for care. And each of the guidelines also has metrics that are recommended to track as these interventions are implemented.
Thank you. So first of all, I love when questions are asked that we were not prepped for. And so I just want you guys to know that. And I love this particular question, and I have two big giant things I want to say about it, and I'm going to do it really fast. So in terms of appropriateness, episodes of care and bundle payment typically is a really good model for addressing the care of the patient who ends up having the surgery, having the episode. It typically, as a model, doesn't do anything to address whether the patient actually needed the surgery in the first place. Did the patient need a C-section? Did the patient need the knee surgery? That is not really what the episode's designed to do. I'm going to save my comment around the Horizon model for just a minute because I don't want to miss the question and the point about how you've built it into the BREE Collaborative. You have those clinical guidelines that you've developed. So from my perspective as the payer, our role isn't to prescribe how the docs actually get there and take care of the patient. It's to build the construct where we can work together to look at the outcomes and the experience. And it is the docs who should be building those clinical guidelines based on the data that we share that gets the patient the most appropriate care at the most appropriate level, and ultimately looking at the variation at the most appropriate cost.
So Lily, describe as an example, take OB, what are the metrics then that you would follow, that you would hold them accountable to?
So OB is a great one. So in terms of outcomes metrics, we do look at C-section rate. We have to in New Jersey. It's a very it's a crazy rate. It's almost 50%.
50%?
50. Wow. 50. Right. And the world, just to give perspective to those who don't know, right, the World Health Organization suggests a C-section is medically indicated between 15 and 20% of the time.
And here in Washington, that's where we're heading. I think we're now in the 20%, 23%.
So so that is one of the metrics. We also look at postpartum visits. We look at, I forget what else we look at. I'll remember in a minute. But if you think about the model I described, if the model was set up so that we were looking at member-specific risk-adjusted budgets, right? And I had a woman with certain comorbidities and risk factors having a vaginal delivery, we would have an anticipated set of costs across the full continuum, right? This isn't just the global payment for the doc. This is everything that happens to that mom as she's delivering the baby. So I'd have a certain level of expectation around the cost. If I have a woman with the same comorbidities and risk factors having a C-section, the anticipated cost would be much higher because the associated cost of the stay, the potential for infection, all of that stuff is much, much higher. It would do nothing to address whether or not the woman, within the episode, the woman would be probably very well taken care of when she had her vaginal delivery and her C-section. In the model that we have, where we're looking at the case mix adjusted rate, if you will, at the practice level, if a practice has a 48% C-section rate, which is very, very typical in my state, and we have kind of a blended full spectrum rate, if the needle moves even just a little bit on that one metric alone, there's huge opportunity for improvement in care for the mom and for the baby and in the dollars, right? So now we've actually got the docs sort of, we're sort of paying to make sure we're paying in line with the outcomes. And there's so much controversy I know around C-sections as an outcome, but it's an easy example to use to say that the focus is really on the full continuum of care. And does the patient need to have a C-section to have a good outcome? And maybe the doc has to talk differently to the patient, educate the patient about why it's dangerous for her and for her baby to stay in the hospital longer, to have a surgical procedure, to be on those opioids.
So what have you seen in terms of changes in the C-section rate among your episodes?
So I love that question too. So it's not as dramatic. I'd love to come here and say it's been really dramatic, but trending, we've started to see the rate of C-sections among our provider partners in the program go down versus the rate of C-section among our non-episode partners, which in some cases has stayed the same or gone up. So we see it trending directionally.
I'm going to move the conversation to a different topic, and I hope it's equally challenging. So One of the most successful strategies for controlling costs and episodes and bundles and various other value-based programs is limiting choice. But as we see from a lot of data that Chris is showing us, patients really want choice. They want to go see the very best doctor. So how do we reconcile those two things? The patient's desire to feel like they're in control of their options versus our desire to limit those options in order to limit costs.
So you're asking me that question first?
You and then Chris maybe can speak to it as well.
So, so we don't limit the patient's choice. They have whatever benefit design that they have. We flag the episode partners like we do all our value-based partners in the directory. I don't know if people even use those anymore, but I should know that. But we flag them. We also share the data with our PCMH practices so that they know which are the practitioners who have the best outcomes, who are the most cost-effective, and having the best quality outcomes. The patient, we do have benefit designs, and there's a sort of a big movement within the organization to really look at, structuring benefit design to support these value-based models, because the belief is these are the docs who are going to provide the best care. At the most appropriate setting and cost.
Yeah, I look at it pretty simply. I mean, it fits an appropriate question. I would be working very hard to put the people who are providing inappropriate care out of business by redirecting away from them using modern tools like we have available to us.
How do you know that?
Well, I think that right now all we worry about is payment, but I think that through some claims analysis, and you can kind of tell some differences between care. I think that it's kind of on the payer probably from that point of view, or the employer what their preference is. But in some well-documented things like you guys are talking about, it shouldn't be too hard to see who's kind of out of the bell curve.
So, well, I mean, is appropriateness then in your model defined by price? And the lower price is the better doc or better provider for the bundle, or how do you do that? Because I think, you said that this is a choice market, but I think as deductibles go up and insurance deductibles are higher and higher, then price becomes a very important driver for patients in terms of, and you're right, patients are looking and shopping a little bit more. But I think in our market, and I asked Nancy if this is true, patients, check me if I'm wrong, are not shopping as much. Right. They're staying with their loyal hospital center and their docs, particularly. But as deductibles go up, I think there will be some shifting. But yeah, appropriateness, I still don't understand how you can deal with appropriateness in your kind of model.
Yeah, I mean, our model is really simple. We want to just build bundles and pay bundles, right? And we communicate clinical information to the patient and to the employer. So if let's say right now the lens that we look on quality is like, if it's part of a large hospital systems, we try to have trust that there's some level of quality there. Most of the things that we sell do not have any significant quality data behind them. I mean, the difference between an image is who knows. Yeah. We have been increasingly getting into more things, and we're trying to be reliant on other parties for that kind of quality appropriate data. But for us, it's pretty hard to influence the clinicians because we're just really a payment model.
Well, we've seen costs go up with huge facility costs that hospitals are now driving. And for instance, colonoscopy. Do you build into the bundle the appropriateness frequency of a screening colonoscopy? You won't pay if it's every 3 years or every 5 years. In this state, recommendations are right at 10 years for most cases. Is that part of your bundle?
Right now, we're mostly self-pay. If it was like a mandated benefit or there was somebody restricting that using our software, we could do that. Yeah. I guess I don't really feel like for us, appropriateness, we're just putting it back on the clinical system.
Yeah.
Dr. Straley, I think I'd like to get your thoughts on a different aspect of patient choice, which is less the appropriateness aspect, but more the sense that I feel like I get to choose who provides me care. And right now, with a lot of the payers that we see who are interested in episodes, there's a limited pool of providers who are in these bundled programs. So there's not a lot of choices folks have, and a lot of plans are trending towards narrow networks, which again make patients feel as though their choices are really limited. So I'd love your policy point of view about that that balancing act.
Yeah, I mean, there's part of me that just says get over it.
Okay.
Because costs are going up, and I think we can't afford the kind of system we have based on the history of choice. But on the other hand, I think to assure patients that these centers of excellence are indeed that, are centers that have high volume, have quality standards, have providers that know what they're doing. I mean, that is the way to sell this. And particularly now for surgical procedures, I think because a patient doesn't have a relationship with an orthopedic surgeon necessarily, they want to, from their primary care doctor, they want to know, do you recommend this particular doctor? I think that's where the trust and the choice begins. And that's why surgical bundles are really a place to start these kinds of episodes. And here in Washington, that's what we hope will get traction in this place. No pun intended about orthopods, but so I think patients have choice, but particularly they want to know where excellence is and that I'm going to get the right care. And I think the systems can assure them that the right care is in these centers of excellence that have the volumes and the quality standards that are above average.
Lily, I think you had a comment.
I
I'll have
did.
one more question, then we're going to take it to the audience.
Okay, thank you. I wanted to jump in on the last question. I love the stuff that you're doing. I think the one thing I would say is the quality piece is so important. From my perspective, the quality piece is what this is all sort of based around, right? When I think about fee-for-service, I think about a system that pays for services that have absolutely no connection to how well a patient fares or how well their experience goes. And I think, a lot of the level of payment that's being made today to healthcare providers across the spectrum, certainly in New Jersey and I think across the country, has nothing to do with the level of quality being provided by that provider. It may have to do with how much leverage they had with the payer. And I like to say, I don't always like to say it publicly and while we're streaming, but I will. We're in New Jersey, very close to New York, and there are parts of the state where we could put a patient and their family, in a hired limousine, drive them into New York City, give them dinner at the fanciest restaurant, put them up in a hotel, and then in the morning give them breakfast and send them back to a part of New Jersey, and they'd have all of that cost plus their surgery for a lower cost and probably better quality than they might have had it if they had just had the surgery somewhere else that was close to their home in New Jersey. So I think it is really important to focus on more than just the cost. The cost might have nothing to do with it.
But I think that's that's what we mean by value.
Yeah, no, I know, me too.
Higher quality at a lower cost, and create the centers that will align with that value.
No, I agree. I was commenting really more, not pointing my finger at,
No,
but just sort of commenting on
I
Chris's
totally
model.
understand. Like, first of all, I completely agree with you. Like, it has to be quality. It's like paramount, right? But what I am saying is that that's on you. Like, you guys should tell us where you want to send your patients, and then we'll send them there.
You, the payer.
The payer, yeah. And I think that is sort of how we behave. I know that that's challenging because it's a lot easier to have an external resource that points the direction, and we could put analytics in our website based on every doctor, just like any current website. We could put Yelp reviews. I mean, we can go through all the quality metrics that you want, but the reality is at some point you know who your good doctors are, and we would like to help you send your patients to those good doctors.
I love it. I'm going to start taking good questions, really good questions from the audience.
Not bad
and we're
questions.
Gonna start here.
Oh, boy. All right. Well, thank you, all of you, for your comments and your presentations and the thought-provoking content that you've delivered. I'm wondering, quite often with a patient, the high utilizers typically have several chronic conditions happening all at once. So as you think about an episode of care, how does that and when is that appropriate when you have someone with multiple conditions that may have comorbidities associated with them?
So is your, that's a really good question. And it gets into, that was a really good question.
There are no bad questions. Yeah.
Oh God, there might be bad answers, though.
Yeah.
So if I understand your question, it's really related to patients that have multiple comorbidities, chronic conditions, and how do we determine whether they're in an episode, what episode they're in, or if they're in at all?
Or how do you think about this concept? Because the way I'm seeing it, or what I understand is that you have an episode of colonoscopy, you might have an episode
Yeah.
of congestive heart failure.
Yeah.
What if they have 3 or 4 of those things going all on at once? Three different things? Is it one big thing? Or
Yeah, so it's actually a great question. It's a complicated set of answers, right? My analytics partners do happen to be here today. I work with HealthQX, who became McKesson and then became Change. So whatever you call yourselves, they can help answer some of these questions afterwards. But basically what happens is if it's a procedural episode, like a colonoscopy, and then there's also a chronic condition, they are typically, and they're completely unrelated, they're completely separate episodes, even if they happen at the same time. And if they happen at different times, it's really easy. If it's chronic, it's happening at the same time. And the costs that are associated to both, if there are, will be attributed to both, allocated to both. If it's a thing called leveling that they'll talk to you about, I won't really talk to you about. But it gets very complicated when you talk about multiple chronic conditions, even a single chronic condition. What we have to do and what we work to do is create with our provider partners, because very much we look to the physician and provider partners as the clinical experts who sort of run with us on this. And we work with them to define what's the day one criteria that lands someone in the episode. If it's oncology, is it the first day of chemotherapy for this particular episode? Is it the first day they saw the medical oncologist? Is it the day they had surgery? What is it? What's this episode going to be? And then we count forward X number of days. If they happen to develop additional comorbidities, the algorithms that we work with are pretty sophisticated and nuanced, probably more than we need. But they will pull in, again, those pieces from other procedures or activities that are occurring simultaneously and apply them to the episode. So they could be in more than one episode at the same time. Does that help?
We've got another question over here.
This is Emily Transu from the Healthcare Authority. Lily, do you envision downside risk being the next step in evolution, and can you talk a little bit about that?
Yes, absolutely. So the program today is retrospective upside only. It means the provider has no risk at all. And I do see it really as an evolution, and I think the next step, and we have a lot of providers who've been in the program since Richard started it and since, who have learned a lot and really are anxious now to take on risk. So I think a couple of things will happen. I think we'll have retrospective models that will incorporate downside risk. And in there we have the lever of shared savings and some others that could be sort of pulled. So if a provider's taking on risk, perhaps their share of savings goes up, their opportunity for shared savings. And then at the end spectrum, and we are launching this year some oncology episodes that will be fully prospective, and the provider will be at risk. And they're really interested in doing that. There are 2 issues that we have with downside risk, and they are the reason that we haven't launched them yet, because we might have done it a little earlier. One is that the regulators in our state have not really been comfortable with providers taking on risk for services they themselves do not provide. And that's actually what the model is, right? You're now responsible for everything that happens to that patient across the continuum. So we're working with the Department of Banking and Insurance with our provider partners to describe the model. And the second is many of our provider partners are not in a situation, they're not ODS, Organized Delivery Systems, which is a requirement to be able to take a payment and make payments or have downside agreements with other providers. So we may end up acting as a TPA, or they may hire one. So there are a number of different ways that it will evolve. But yes, that's definitely sort of the next step. And I think there'll always be a mix of those. I don't think we'll ever get at Horizon or in the country to a place where everything is prospective. I see that. I think it will always be sort of some mix of that.
Yeah, just a comment. There's a lot of unintended consequences that come out of the back end of these episodes around quality. A UCLA paper in 2016 delivered at the AOS talked about driving down the length of stay for total joint replacements, and sure enough, the ED visit rate went up, and sure enough, the readmissions rate up as high as 15%. So the warranties on the back end are really critical. My question is really more about the digital health, and what we're seeing in these clinical process models, particularly for total joint replacements, is the providers are moving so fast in changing and shifting the place of care. We're seeing, for example, SNF usage go from 15% down to 5 and 10% with the over age 65 population. And what we're seeing also is the reimbursement's not keeping up with these changing models. And specifically telehealth, we can do so much more in remote patient monitoring in the homes, yet the payment is not there for the use of the telehealth. Right. And particularly for home exercise programs and remote IoT, we're not using those G codes. So I think the payers, while they provide the opportunity to do this, they're not providing the payment models for digital health technologies that can really get us out of those high-cost hospitals. So I'd like you to comment on how you're keeping up with the clinical process changes which the providers are driving through the innovation, and making sure that we're getting reimbursed to use these technologies to drive the patients out of the hospital, for example.
So I guess that's me again. So first, the unintended consequences of the episodes and any of the value-based models. I think one of the big fears always is underutilization, right? That cutting corners just to earn. It's why the quality piece is, and the review of outcomes measures is so critical to make sure that that does not happen. And to build in, I never use that term warranty, but it means really, that the episode lasts beyond the point of the procedure, right? The 90 days after a surgical procedure or whatever it is, to make sure that you capture infections, readmissions, ED visits, things like that. So we do really take that very seriously. The other question, I think you're right around telehealth, and I don't really know how it's being priced in my own organization, but I do know it's sort of new and growing, and it's at even an earlier stage of evolution than this is. I think we will get there. It probably not as fast as we need to, but none of this is going to get there as fast as we need to. But we're starting it. We've started it.
I know a lot of folks have questions, but we have a bunch of breakout sessions where you'll be able to answer a lot of them and discuss a lot of those answers with one another. So the conversation's not ending here, but we are running out of time. So I'm going to pass it back to Nicole.
Well, let's just thank Tamara, Chris, Lily, Dr. Straley for their insights this morning. And I will excuse you for a time, and it is true, they will all be in the breakout sessions past the break. We are about to break, but not at this moment. We have one quick exercise before we go, and that is to set the stage for what's going to happen when you return from bio breaks, water breaks, etc. And so if I could have Jenny Weir from the Break Collaborative come up here, as well as Dorothy Teeter. We're going to run through a quick visionary exercise. And so we heard from Dr. Straley this morning about the state goals for 2021. And so we're effectively right now going to crowdsource a fill-in-the-blank exercise to set the stage for what we will do in the breakout sessions. And so if we were to dream right now what we could do in Washington State, starting today, realizing by 2021, and using episodes of care, what would we do? So I've got Jenny and Dorothy here to help us seed the conversation, but we would like you to speak up, and we're going to live edit this very quickly so we can send you off to the break. Any thoughts? Any questions? Yes, Robin. Fill in the blank. Yeah.
I know you all have a lot of ideas.
So I think we could be the first to educate and incentivize consumers to understand value and quality.
So educate consumers.
We could be the first in the nation to design care around people instead of diseases.
Other comments? A lot of patient-centered language. I like this a lot. What about quality? What does that mean here? What could we talk about in terms of quality? Otherwise, we'll have to call on people. Oh, there's one.
The first to design bundles around specialty areas, such as musculoskeletal, which would deal more with the appropriateness issues.
People aren't grouped together where they're wanting to make comments.
I'll add a little prefix to it. The first state in the country to build on King County's longest running behavioral health case rate model in the country, and build case rates or bundled payments for behavioral health services throughout the state.
Okay, behavioral health, look at best practices. Other thoughts?
How about something around payers? Anything Washington State and payers? Are there any payers here?
Well, I was going to say something around costs and be the first to actually lower year-over-year costs per capita. 'Cause I don't think that's ever been done before. So.
Oregon's done it.
Yeah, Nancy. Oh, here, we'll get these mics. We didn't practice, obviously.
I would say the first in the country to really measure value for bundles, and to me that means cost, quality, and patient experience all together.
Here's somebody in the front here.
Riffing on that, maybe the first state in the country to have cost and quality actually be aligned, to see those prices.
This makes me want to beat Oregon.
Yeah. Can we just say better than Oregon for those that, are competitive?
Just to pick up on your comment, to standardize the care protocols across payers so that providers don't have to practice differently.
To augment the first bullet, I would say listen to and engage and activate consumers. Not just it's not like we're telling them we need to listen. It needs to be bilateral.
Can I add something to that, just personally, which is, it really relates to having
being able for consumers or patients or whatever we want to call ourselves, be able to use online tools in really good ways to get to the right provider for the right services in the case that you've got that kind of a coverage option where you're not referred.
And then I guess let's just keep going, and that is that there's an outcomes on the other side of all of this. And those improvements, those significant improvements in outcomes, which then back into prevention and real interventions that matter, that are delivering value on the patient's terms in the way they need to be digesting and using.
Establish quality metrics that allow us to determine if the patient was actually cured, particularly as it pertains to musculoskeletal diseases where a cure is often expected.
So follow-up data.
And just to add to the patient experience list, to have patients as part of policymaking. So for example, were patients involved in any of the decisions around the 3 speakers organizations that we heard about, and should they not be at that table?
Yeah. Involving at the front end. I think that's really key.
You didn't put that one up here about better than Oregon. I guess we wouldn't be the first state to be better than Oregon, though. Sorry. We just have to keep up that competition. Yeah, I think so.
Seems like it.
I like all of these, and I'm wondering if there's a way to make it, talk about implementation or delivering it, because a lot of this to me, as I read the language, is about developing metrics or focusing on quality, but it's not going to happen until we actually implement it. So if there's some language or something around implementing some of this and having it being used in practice by 2021.
Yeah. Pragmatic approach. Yeah.
Is somebody back there?
So let me build on that last comment. How about we're the first state in the country to do for healthcare delivery what Washington, D.C. has not been able to do.
I see. Michelle, do you still have a
Healthy
comment?
competition.
Just to build on the implementation, something about adoption by a high percentage of providers and payers so that employers don't have to make tough choices and be perceived as narrowing what's available to their employees, because employers can't get on board if it just looks like they're doing a takeaway.
That's a key perspective. We have a comment over here.
That's great.
I'd like to see us be the first state in the country that has complete transparency about cost and quality metrics across a spectrum of diseases that we all care about.
Integration between clinical and medical data. Complete integration.
Can we get one more here?
I'd echo the employer comment, but from a provider perspective, I would say to have the market be dominated by value rather than volume, so providers as well are not trying to straddle both of those so much.
Okay, well, thank you all for your comments.
I think we're done with this part. Is that right?
I can release Dorothy and Jenny. Thank you so much. And
Thank you.
with this in mind, I want to bring up so you can see who they are, Avthar, Matt, and Jerry, who are going to facilitate, after the break, our 3 breakout groups. And so each of them is going to be assigned, and each of you is going to go to a specific area of the Cambia Grove. And right here will be the process group. The Fremont room, which is across from the restrooms, is going to be the people group. And around the corner here is going to be the tech group. So can each of you identify what group you're with?
I'm doing the process group right here.
And
So I'm going to be working with Lily and Ginny on the process side over here. My name is Avtar Varma.
And I'm Matt Holman. I'll be leading the technology group with Richard and Chris, and we'll be just around the corner in the boardroom.
Hi, I'm Jerry Tolzman. I'll be leading the people group along with Tamara and Nicole, and we're down the hall across from the restrooms.
So we'll see you there in a few moments, but more context about what we mean by people, process, and tech for these breakout groups. So for people, we're going to be really exploring the customer journey. And so this is the perspective and the lens of the human from the moment they feel ouch to the moment their episode